over to her. So we are good to go. So I'm going to turn the floor to you, Dr. King. It's all yours.
Okay, great. All right, can everyone see that okay?
You're good.
All right, great. Let me just minimize this for myself. Okay, so thanks everyone for coming tonight. Like Mallory said, we're going to talk about trauma in the family system and how it affects the family and what to do about it. I am Dr. King. I am the supervisor of trauma services at Caron PA's campus. So the residential campus in Wernersville, PA. Sorry, I'm not sure what that was.
It looks okay on my end.
Okay. Sorry about this. I don't, my computer. Okay.
There you go. Yep, you look good now.
Okay. So I provide trauma services to patients at Caron Residential, from young adult up to older adults. So we will talk tonight more generally about what trauma is, what PTSD is. We'll discuss how trauma affects the brain and how trauma affects different emotions, the way that people think about things, and how those affect the relationships. We'll discuss how trauma is related to substance use disorders, and then really focus a lot on what family members can do to help support a loved one who might be experiencing trauma or post-traumatic stress disorder. So it's a tall order, so we're just going to be briefly touching on each of these topics. So each of these topics could be an hour-long presentation itself. So you might have some questions about any of these areas. Like Mallory said, please feel free to put them in the chat, or we can talk at the end if I don't touch on it during the PowerPoint. Okay, so first of all, why is it important for family members to be educated on trauma? So traumatic events are actually way more common than we realize. So in worldwide studies, looking at the general adult population, over 70% will experience at least one traumatic event in their lifetime. And about 30% of those will be exposed to 4 or more traumas in their lifetime. So the vast majority of the population is going to experience at least one traumatic event in their lifetime. From those numbers, approximately 30% will go on to develop PTSD. So not everyone that experiences a traumatic event will develop PTSD. So another really important reason why family members should be educated on trauma is that symptoms serve a function for that person. So the post-traumatic stress symptoms that we see with the traumatized individual were once either a method used to try to survive, whether that be surviving that traumatic experience or the aftermath. It could be an attempt to process or to make sense of the traumatic event that had occurred, or it could be a way that they are trying to protect themselves against future traumas. So if you're not the traumatized individual and you're only seeing the symptoms or the way that a person is behaving, it could be very confusing or frustrating. And when you're a family member or a loved one of someone that experienced a traumatic event and developed PTSD, we really encourage folks to try to do the best that they can to understand where the symptoms are coming from, so that you can be a better support for that person. And so ultimately the family system can function as healthily as possible. The next really important thing is that just like in substance use, recovery from trauma is possible. And it's even more possible when patients have family members encourage them to stay in treatment. So we see in studies that if a patient that is experiencing trauma-focused treatment has a loved one, whether that's a family member or a close friend, encouraging them to stay in their trauma treatment, they're 50% more likely to remain involved in the treatment. So we know the treatment works, and we just need to help the traumatized person stay in the treatment that we know is going to be effective. That's especially important when things become really challenging or emotionally painful as they're processing past traumas. All right, so you've probably heard the word trauma used a lot to describe things. So I want to give a clinical diagnosis of what we mean when we're talking about a traumatic event. So the DSM-5 TR is the diagnostic manual that's used to make mental health diagnoses. So this is the gold standard for mental health professionals to look at to see if a person meets criteria for a diagnosis or not. So they set forth this diagnosis. So a trauma requires actual or threatened death, serious injury, or sexual violence. And so that could be the person directly experiences those things, they directly witness it, or they learn about those things happening to a close friend or a family member. So the definition from the DSM of what a traumatic event is actually rather narrow compared to how it's used in common linguistics in our society now. What we generally hear about is usually what we would categorize as more adverse experiences. So stressful or adverse experiences that are not involving immediate threat to life or physical injury are not considered a trauma according to the DSM. So that would be divorce, job loss, bullying, and other things that, again, are not directly related to physical threats to one's life or just their physical well-being. So sometimes we see, though, that people, for example, that might experience a lot of emotional abuse, where there's a lot of belittling, name calling. It doesn't necessarily threaten their physical health, but with prolonged emotional abuse, people can have symptoms that look exactly like PTSD, but again, they're not going to meet the requirement for a traumatic event. So you might have heard of other diagnoses such as unspecified trauma and stressor-related disorder or other specified trauma and related disorder. So those are just highlighting that a person meets most criteria of PTSD, but not all. There's other things such as an adjustment disorder. So for divorce, for example, a person, that's certainly an adverse life event for most people. And most people can experience some symptoms of depression and anxiety. And they might meet criteria for an adjustment disorder, but not for PTSD, because again, it's not considered traumatic according to the DSM. And if you yourself have experienced a trauma, or a family member or close loved one experience a trauma, it can look like, if they develop PTSD, it can look like a number of things. So here are some examples that people might first identify before realizing that some of the symptoms are actually rooted in a trauma. So people might experience depression, or there might be sleep difficulties, or there might be unexplained pain or low energy. And if someone goes to their general practitioner that is not a mental health professional, or not aware that the person experienced trauma, or they're not a trauma-informed provider, they might not understand or be able to categorize the symptoms that a person's experiencing as trauma. So what we generally see is that people go for a long period of time before they get a trauma diagnosis. So a lot of times, especially at Caron, PA, we see a lot where people come and they have gotten diagnoses of depression or chronic pain or anxiety. And in a thorough evaluation with trauma-informed professionals, we are able to uncover that a lot of the symptoms that a person initially has come with are actually rooted in trauma, and they meet criteria for PTSD. And so if that's the case for a person, it's really important to get an accurate diagnosis so that you can get connected to appropriate treatment. So if your loved one has experienced a trauma and you are identifying with a number of things on this list, it might be worthwhile to have an evaluation to see if they do meet criteria for PTSD. So let's talk a little bit more about the specific criteria for PTSD. So again, the first thing that a person has to meet is they have to have experienced a traumatic event. And again, the traumatic event, according to the DSM, has to include some issue with harm to physical integrity. Again, whether it directly impacted the person, whether they witnessed it, or they heard about it from happening to a loved one. So that's number one. And then we see symptoms typically fall into a number of different categories. So people typically experience intrusive symptoms. So this is where somebody might struggle with nightmares related to the traumatic event, or they have flashbacks where they're all of a sudden experiencing symptom or experiencing reminders of that traumatic event and feel like they're reliving that traumatic event, even though it happened in the past. They could also just have intrusive thoughts related to the trauma. So this is where somebody might be just trying to go along their normal day. Maybe they're in a work meeting and a random thought of the trauma pops in their head. So it's an intrusive, unwanted experience. We also see changes in arousal. So folks experience difficulty with sleep. They might experience irritability or anger, or this could just be a person that's just on high alert. They may be easily startled. There's somebody that might jump if they hear a loud noise in their environment that wasn't expected. And we'll talk a lot more about why that is in a few slides. We also see general themes of negative thinking. So this could be a person experiences excessive guilt, so they might be blaming themselves. They might experience some shame, so they might be experiencing some global symptoms of I'm a bad person. Just general self-defeating thoughts or negative self-talk is very common with PTSD. Another really common symptom cluster is related to avoidance. So this is where a person is trying to avoid reminders of the trauma in any form. So that could be people, places, or things. Avoidance could be, for example, if someone was in a car accident and developed PTSD, they might avoid driving the car. For other people, it might be that they have to avoid certain people or certain environments. We also see that, especially the folks that struggle with substance use, that substance use is then a means of trying to avoid. So people might be distressed by those intrusive symptoms and they turn to substances to try to numb and to try to forget about what they're experiencing. So we see that very commonly for people with PTSD. You also might have heard of the term complex PTSD. So complex PTSD is not in the DSM, so it's not an official diagnosis, but it is out there in just the normal linguistics that's going around in our culture. And it is really highlighting just the more global effect that it can occur when someone experiences chronic and repeated traumatic events. So when someone experiences domestic violence, for example, so it's repeated violent experiences over time that can lead to more cumulative effects. So we see that symptoms can be more impairing and can be more global. So again, it's not a formal diagnosis in the DSM, but it is certainly different symptom clusters that we see. Again, the diagnosis would still be PTSD. So here are some differences or more global, more impairing symptoms that you might see when someone experiences more chronic and repetitive traumatic events. So you might see some dissociation. So this is where someone feels detached from their body, from the environment, or others. So this is where someone might be just appear totally detached and disconnected. So you could be talking with someone, and if their trauma gets triggered, they just literally, their mind just drifts away. And it can be really impairing for folks, especially if they're having these trauma triggers a lot. So if they're getting triggered a lot and they end up dissociating a lot, they're going to lose a lot of time and productivity. So they might not be able to function the way that they once were. They might not be able to be connected to other people or to themselves. Another area that we see is distorted perceptions of the perpetrator. So again, with the domestic violence example, from an outsider, someone might say, like, why isn't that person leaving? And when someone experiences PTSD, their perceptions of the person that is perpetrating against them can get distorted. So they can see the perpetrator as having all of the power and they've lost their power. We see the flip side sometimes too, where a person becomes preoccupied with revenge or trying to get back at a person. We also see the distortions in explaining the perpetrator's behavior. So people might start rationalizing or minimizing the perpetrator's behavior in a way to try to really avoid the feeling the intensity of the post-traumatic symptoms. We also see that it affects relationships with other people. So when people experience that chronic and repetitive traumatic events, they tend to start isolating from other people. They might get a lot more mistrustful, or we can see the other side of it is that they want someone to fix them or to save them, and so they might attach or get very dependent on other people. So these are just some general symptoms. It really is going to be very individualized with how the person experiences and processes the trauma that they've gone through. We also see that folks can experience significant changes in their systems of meaning. So one of the ways that we try to heal from trauma naturally is to try to make sense of it. And one way people might make sense of it is that they might lose their faith. They might have been a faithful person, and then they're not able to make sense of why the trauma occurred to them. So they might abandon their entire faith structure to try to make sense of what happened to them. We also see that people can have breaches in their integrity or their values, especially as it relates to when their trauma gets triggered. So they might be someone that really values their relationship, but when their trauma gets triggered, they get very mistrustful and want to isolate and be away from people. People can lose their sense of purpose in life. So this is where we can see a spiraling of some more depressive symptoms. Again, as people are trying to make sense of what happened to them, it's often challenging without professional help. So we can see people just really struggling with that process to the point where they lose their sense of faith or their sense of purpose. So let's talk about why this occurs. So this is going to be a brief overview of what happens as the brain tries to process information. So again, this is just a gross overview. It's not technical or medical by any means, but let's try to follow the arrows. So something happens in our environment. So that is any type of sensory information. So you're seeing me on the screen, you're hearing my voice. The thalamus in your brain is picking up that sensory information. So we don't have to think about it. Our thalamus is just absorbing the sensory information in our environment all the time. And it sends that information to the amygdala, where the amygdala is able to very quickly assess, is this safe? Is this not safe? And the amygdala does that in communication with the hippocampus, which is our memory storage. So if someone is processing something as in a regulated body who does not have PTSD, so they're going to experience the sensory information through the thalamus. The thalamus quickly is communicating to the amygdala and the hippocampus. So what you're experiencing now is hearing my voice, seeing me on the screen. So you might be sitting at home, so you're picking up all this sensory information, where hopefully your amygdala and hippocampus are talking and saying, yep, I've been on a Zoom call before. Nothing bad has ever happened to me. I'm sitting at home. I feel safe and comfortable. So the amygdala says, yep, we're safe. Like, continue on processing the information. So then the hippocampus sends the information to the prefrontal cortex, which is the more, the higher level area of the brain to process more complex things like planning, goal-directed behavior, and inhibiting impulses. So the hippocampus is able to communicate with the prefrontal cortex. So you're able to sit with me right now, digest this information, maybe think through some questions you might want to ask me later, or you might be able to inhibit the impulse of unmuting yourself and asking the question right now because you have access to the prefrontal cortex. So what we have is a thoughtful, planned response to the stimulus that is in your environment. Now, the process can be completely different when we're dealing with a traumatized brain and when the brain is triggered. So what happens is the thalamus, again, is picking up all of the sensory information in the environment, and it's sending it to the amygdala. And so what happens is, so say you have experienced something traumatic on Zoom by somebody that looked like me. Say, for example, someone was fired on Zoom. Again, it's not a traumatic event according to the DSM, but it's an example. So if someone was fired on Zoom by someone that looked like me, your thalamus might pick up like, oh no, this could be a really scary event again. So the amygdala is again going to assess, is this safe? Is this not safe? And when the amygdala says it's not safe, it stops communicating with the hippocampus and goes right to the hypothalamus. And the hypothalamus will shut off all communication to the prefrontal cortex. And what we have is a more primitive level of the brain operating and processing information. And so the hypothalamus releases stress hormones, and we go into survival mode. And what we see is people have an instinctual reaction. So this is where people get thrown into the fight, flight, or freeze. So the body really is in survival mode and trying to protect the body from experiencing another traumatic event. And what we see is when that traumatic event, or when there's any type of sensory information that represents the traumatic event or reminds the brain of the traumatic event, the brain can then go into that survival mode. And again, we lose access to higher level thinking where we can have that thoughtful, planned response. So what we see is when that happens, people are thrown into either hyper aroused or hypo aroused. So they're really knocked out of their window of tolerance. So the window of tolerance is where we can be present and grounded. We can feel our feelings. We can pick up the sensory information in our environment and think through it logically. But what happens again is if there's any type of trigger in the environment that reminds the brain of that traumatic event, a person can get quickly thrown into that hyper aroused where they experience a lot of anxiety, they feel overwhelmed, they feel that like hyper vigilance where they just have to be super alert to their environment. Or it can throw them into the hypoaroused, where they can sense that this is not safe and they go into shutdown mode. So they might shut down, they might feel very numb. This is where they might dissociate. And so when a person's trauma is triggered, that's where we see the symptoms occurring the most. And so like I had said earlier in the presentation, some of the symptoms that we see are because the brain got hijacked by the trauma trigger. And so what we need to do, or what the person needs to do, is figure out a way to soothe their body, because we need them to get to the window of tolerance where their body and their emotion are more regulated, and then they can tap into the frontal cortex where they can start thinking through things in a thoughtful, planful way. Okay, so this slide just kind of highlights what we're talking about here. We're talking basically about the difference between instinctually reacting and responding. And just a quick little language description here from Latin is, if we look at re for both, it is showing action in answer to something. So we are responding, or there's some kind of action to the stimulus in the environment. But when we're reacting, it from the Latin meaning is to move or to do, whereas respond is to pledge or to make a promise. So it is a more thoughtful way of trying to approach a situation. And that's what we're really hoping for people to be able to be in a place where they can respond in a way that they're able to think through and plan how they want to respond to the stimuli. I really like the image at the top left here because I think it highlights, or it symbolizes the different perceptions of the same exact situation. So if a regulated brain sees that, they probably see that small little figure. It looks like a blue figure, the actual person. A traumatized brain is likely to see that big, scary shadow figure. And so they're going to respond to the big, scary shadow figure rather than being able to fully assess the situation and see that it is this little person, and there's probably a light that is casting the shadow. So the same two people could be looking at the same situation, but if a traumatized brain gets triggered, again, they're seeing that scary shadow, and a non-traumatized brain sees that the actual little person there. That non-traumatized person could look at the traumatized person and ask, like, why are you acting this way? Because what's happening internally is they're perceiving the threat and they are reacting to the threat that they're perceiving, even if the threat is actually not there. It's their brain's reaction to try to protect them from any potential reminders of that traumatic event. The brain does not want that traumatic event to happen again. Okay, so let's talk a little bit about trauma and cognitions. So we talked about how it affects the brain and affects emotion, but we also see it affects the way that people are thinking about things and some of their beliefs. So one common way that we see is that the traumatic event conflicts with originally held beliefs. So For example, if someone has the belief that good things happen to good people, bad things happen to bad people, and if they believe that they're generally a good person, and then this bad traumatic thing happens to them, they have to make sense of that conflict. And what we see is that, again, people try to make sense of their trauma. That's one of the ways that we heal, is trying to make sense and make meaning of it. One unhealthy way is that people could then adjust their beliefs. They could say, well, I guess I wasn't a good person. Or they could say, I've always believed that what goes around comes around, so I must have deserved it. So they start adjusting their belief sets to try to make sense of the trauma. The other way we see it is that the original belief gets confirmed, or seems to be confirmed by the person with that traumatic event. So, for example, if they believed I'm a bad person, so maybe they had low self-esteem to begin with, and then the trauma happens, then they could use that, it filters into that I'm a bad person. They could say, see, here's another example of me being a bad person. Or the other example we have on the slide here is, I've always been irresponsible, and the trauma is just another example of that. So it can cause that worsening of those already existing unhealthy beliefs. And what we see is that this plays out in their relationship with themselves, other people, and the world. So when someone's experienced trauma, we see it in their relationships a lot. So here are some of the themes that you might start seeing if one of your loved ones has experienced trauma. So you might see that they struggle with fears of abandonment, or tremendous instability in their relationships, or significant mistrust. They stop trusting other people. They might stop sharing their emotions. So there might be that emotional deprivation. So they don't want to share. There might be that intimacy issue. Like I said in the past slide, they might have that sense of defectiveness and shame that then reverberates through all of their other relationships. So we'll go through each of those themes, but we will go into a little bit more about how trauma affects relationships in terms of boundaries. Okay, so what we want to see is healthy boundaries. So typically people that have experienced traumatic events might struggle with having healthy boundaries. So I wanted to just lay this out of what we would typically expect. What is the goal that we would be working towards with that person? So some of the goal is being able to take responsibility for your own emotions, not controlling one another, being able to trust each other. So being separate entities, but still close enough that you can be supportive of each other. And people typically feel supported when there are healthy relationships that are healthy boundaries in a relationship, and you can develop a more secure sense of attachment to that person. The challenge comes in is that a lot of times people struggle with taking ownership and accountability for their own emotions, especially if someone is turning towards another person to try to help them cope or regulate, or to try to avoid what they're feeling. People also tend to struggle with not controlling other people, especially if somebody had any pre-existing codependency issues. And again, with trauma, trust is often impacted, especially if it's any type of interpersonal traumatic event. So this is what we're trying to reach for. What we typically see is that when someone experiences trauma, it affects their boundaries. So people sometimes fall into having very distant boundaries. They're very avoidant of close contact. So for people that are engaging in these distant boundaries, they typically feel safe. If they experienced an interpersonal trauma, then one way to try to protect themselves is to stay away from other people. So they do feel safe, there's less conflict, but some unintended consequences could be that they feel lonely or that they don't have the support when they need it. And they're not connected to a community or to other people that could provide them that support. Another way that we see it is with people with fused boundaries. So we talked about that on the slide with distortions of the perpetrator. So sometimes people try to fuse with another person or try to find another person to help save them or to fix them. And so there might be this fusing of the boundaries where the person kind of loses their sense of who they are, their autonomy, their independence, for the sake of trying to maintain very close enmeshed relationship with another person. So they might feel connected, they might feel in sync, they might feel supported. But again, some of those unintended consequences are that they could then lack individuality. They could lack their individual goals. They could lose a sense of their identity. So this is another one where it's not healthy. We do not want the person to be having those fused, enmeshed boundaries. Other experiences could be disorganized boundaries. So this is really a blending of the two that we just talked about. So either really distant boundaries or really fused and meshed boundaries. And it happens in a disorganized, unpredictable way. So sometimes they want a lot of distance, sometimes they want a lot of closeness. It's very stormy or sunny. And for someone that experienced domestic violence, or if someone experienced childhood abuse of any kind, relating to somebody like this could feel familiar. And that's where the benefit comes for a person, is that if it feels familiar, they know what it's like. And we know that there's a lot of unintended consequences with this. People that have a healthy attachment style or healthy boundaries get really exhausted by the back and forth and the unpredictable nature. So while there might be someone that's supportive in their life for a period of time, people tend to want to pull away from this type of relating. So it really does pull away a lot of support and connection for the person. And it leads to chronic emotional dysregulation, or the emotional dysregulation could be a byproduct. They're very, they influence each other pretty significantly. So these are some things that you might have started to see in your family relationships or close friendships after somebody has experienced a traumatic event. And again, the goal is going to be to help that person in your relationship with them to get more into that more healthy attachment and healthy boundaries. Okay, so that is just that brief overview. Again, we probably could have done a lecture on each one of those categories, but I really wanted to make sure that we had enough time to talk about how do we start healing and how can we help offer support to family members or loved ones who are struggling. I want to quickly go through the cycle that can occur with substance use disorder and PTSD. So this is what can happen if someone tries to get sober without treating PTSD. So if they're not working a program of recovery for both their substance use and their trauma, this is what can happen. So first, someone tries to stop using and they try to get into recovery. What we see, again, if they have been using to try to cope or to try to avoid, we typically see an increase in PTSD symptoms. So those intrusive symptoms come back, the changes in arousal, the negative cognitions, all of that starts to come back. And that really leads to them being at very high risk for starting a relapse. what we see is that sometimes people might start feeling ashamed that they're experiencing PTSD symptoms again. So they might start hiding that they're really struggling. They might start pulling back from people. They might start telling half truths. And what we know is that that's the start of some relapse thinking. Then we might see an acting out. We might see a complete slip or complete relapse. So if a person is experiencing symptoms and they're not fully sharing with their support system, people typically only can feel strong PTSD symptoms for a while before they start looking for relief. And if somebody is in early recovery, they're going to be at very, very high risk to turning to substances to try to get that relief. So if they try to turn to substances or any other acting out or process addictions like gambling, promiscuity, shopping, it then leads to additional consequences. So they might start experiencing issues at work or issues in their friendships. They might have financial difficulties or legal difficulties. They might even expose themselves to additional traumas in that relapse or that slip. And so the cycle could start all over again. So again, this is only if a program of recovery has not worked for both the substances and trauma. What we see is that we need treatment for both to occur simultaneously. So the gold standard is integrated simultaneous treatment for trauma and substance use. So I included a couple quotes here because I do think it's pretty helpful to know these are trauma professionals in the field who see it also very similarly. So this first quote really highlights what I've been talking about the different perspectives and challenges in changing old behaviors or old patterns that were used to survive. So Dr. Roberts writes, although it may make perfect sense to the observer, what is new and healthy in terms of behavior and action can be very scary to the individual. What is old and unhealthy is familiar to the patient and thus comfortable. So again, the meaning is that the symptom really is a way that a person has tried to survive. It's a way they tried to make sense of their trauma, and it's familiar. Trauma treatment is painful and it's scary. One of those symptoms of trauma is avoidance. So a lot of people that experience PTSD are reluctant to go into trauma treatment because one of their symptoms is to try to avoid, because thinking about it and talking about it is initially very painful. So as an observer, it might be hard to understand why there might be some avoidance of going to trauma treatment. And hopefully after the end of this webinar, it makes a little bit more sense. Similarly, what we see is that if someone is trying to get sober and they're working a program of recovery, and they're really having a hard time maintaining sobriety and recovery, there might be some unresolved, unhealed traumas underneath of that. So that could be something that the person is not fully aware of yet, or it could be that that person hasn't shared that with you. And maybe they're aware that there's these unhealed traumas, but their support system isn't aware of it yet. So if a loved one or yourself are trying to maintain a program of recovery and continue to have some difficulties with it, it might be worthwhile to look at to see, is there other traumatic events that have occurred in your life or their lives that need some trauma treatment. And again, we see time and time again, the gold standard is to treat both at the same time. So if you hear providers that say you need to be sober before you can treat the trauma, or you need to treat the trauma before you can be sober, that's really an old school way of thinking. And what we see now is we see so much success in addressing both at the same time. So what do we do? So the goal is to develop resiliency. So resiliency, the general definition of it is an ability to recover from or adjust easily to misfortune or change. And so the misfortune has already happened. So the person that has PTSD already experienced the trauma. What we need to do is work towards resiliency after the trauma. So that is in the face of those triggers or additional adverse experiences, we need to help them build up their resiliency. So there's 3 key ways that I want to touch on here. The first one is regulate. So this is an absolutely essential starting point. So as we saw in the trauma in the brain slides, a person's brain could get hijacked from a trauma trigger. And what we need to teach that person is how to regulate their body. So if they're in that hyper-aroused or hypo-aroused state, they're not going to have access to the higher level thinking that they could if they were in a calm state. So some strategies to do this are really implementing grounding techniques, working on a variety of coping skills. Yoga is fabulous. Any type of really breathing exercises that pair breathing with movement, really helping a person just regulate and control their breathing patterns is going to be helpful. Mindfulness also falls into this category. Again, anything that can help a person regulate their nervous system. Relating is also so essential. So this is connecting to other people and being in safe and supportive environments. So we know that recovery communities are essential for recovering for substance use, and that can also have a healing effect for someone dealing with PTSD. So they don't need to have a separate recovery community for PTSD. If someone is in AA or Smart Recovery or Dharma or any recovery program where they're connected to other people and feeling safe and supportive, is going to be healing for them. So that process is naturally going to have them start challenging any of those cognitive beliefs about the world being unsafe or people being mistrustful. So if they're in that supportive environment and connecting to other people, it's going to naturally help them to start challenging that. And that's the next one, analyzing or reasoning. So as we talked about in the cognition slide, the person that experienced the trauma is trying to desperately make sense of what happened and why. So if they've developed any of those unhealthy beliefs, they really need to start working on skills to analyze if those beliefs are helpful or not. So they want to look at, are they fact-based? This could be where someone applies any CBT, cognitive behavioral therapy, or DBT, dialectical behavioral therapy skills to help them sort through, is their thinking clear and logical, and is there evidence for that? There's also very effective trauma treatments. I've only included 2 here. There are others. EMDR and CPT have very strong research backing. So EMDR is eye movement desensitization and reprocessing. CPT is cognitive processing therapy. So if your loved one is struggling or you yourself are struggling, here are 2 wonderful evidence-based trauma treatments that can help you in your trauma recovery. I also included some just general reading material because part of trauma recovery is just understanding how trauma can affect a person, can affect a family system, and then starting the process of learning what to do about it. So here are there's 4 key books here that are really well known in the field to try to help that process, to understand why trauma is so profoundly affecting many people. So I do caution people sometimes with The Body Keeps the Score by Dr. Bessel van der Kolk. It's a fabulous book, but there's a lot of trauma detail that's in the book. So if you're currently struggling or someone is struggling with really active trauma symptoms, you might need to put that book on pause, or really only read it in small chunks when you're around a lot of supportive people, because it can be triggering for some people. Now, specifically as a family member, what can you do? So the number one thing, as you've probably heard in helping a family member who is actively struggling with their addiction or is in recovery, is to prioritize your recovery. The same thing can be true with trauma recovery of a loved one, is that you need to be well. You are also going through a lot. As you saw, as I mentioned in the beginning, that learning about a family member's trauma could cause PTSD symptoms in that family member. So making sure that you are well as you're trying to do the best you can to support a person that you care about is really important. So that could look like a number of things. It could look like Al-Anon meetings, ACOA meetings for yourself, your own therapy, or your own general self-care, whatever that might look like. I also recommend doing the best that you can to display patience. So hopefully some of this information is new to you and it has helped you see things from a compassionate perspective if you weren't there already. It can be really helpful for a traumatized person to have some assistance in knowing when their trauma gets triggered, because again, they don't have access to the frontal lobe that helps them think through and fully understand what's happening and fully assess their environment. So this could look like presenting to a family member of, hey, I know this has triggered you in the past. I wonder if you're triggered right now. Maybe we can do something to try to cope right now. So the next bullet is to help them establish a sense of safety. So that might be, let's take a few deep breaths together. Let's regroup before we get out of the car and go into the store, or whatever the situation is. If that person is in that trauma activation, it's going to be really hard for them to do a healthy coping skill in the moment if they haven't practiced it already. So if you're in their life, it's good for them to have reminders to just practice their healthy coping skill in moments that they don't need it. So if they're calm, that's a great time to pull out some of their treatment work and do some practice of their treatment work so that it becomes more habitual when they're in crisis and they do need to use it. And again, encouraging them to remain in treatment is going to be really beneficial. We see that in research. They're 50% more likely to stay in treatment if they have at least one person encouraging them to remain in treatment. And again, that can look like, hey, I hope you stick it out in therapy. I know it's tough. We're not encouraging anyone to veer into any more like codependency behaviors where you're trying to actively take care of the person. This is really just encouragement, especially if they're having a hard time and struggling. Providing a lot of validation and reminding them that treatment is effective. It might be hard and challenging at times, but that they can do it. So that encouragement goes a long way. And that is everything. Here are some of the references, and that is all. So thank you all for listening. And I think we are going to, it looks like it's 8 o'clock exactly. And we will turn it over to some questions.
Thank you so much, Dr. King. Let me just stop the recording.